Hi everybody, this is Mrs. Poindexter. We are going to do a review of the respiratory disorders, part 2, which we're going to talk about what happens in the lower part of the respiratory tract. Really, that is where the magic happens, gas exchange. So obviously any conditions that are going to cause some problems is obviously going to affect breathing and O2 exchange. So just remember your 6 P's of dyspnea, and you can take a few moments to look at this. So infections to the lower respiratory tract, we're going to talk about pneumonia and tuberculosis. Causes of pneumonia obviously can be viral, fungal, bacterial, can even be caused by parasites. It is categorized by different classifications, whether it's community acquired, hospital acquired, obviously healthcare associated pneumonia and ventilator associated pneumonia, which you will see more with your critical care patients. Findings: anxiety, fatigue, weakness. Sometimes there can be confusion from hypoxia. It is most common, especially when you see older adult clients, so kind of keep that in mind. Some of the physical assessment findings: fever, chills, flushed face, shortness of breath, or difficulty breathing. Sometimes you'll hear crackles and wheezings in the bases of the lungs, and coughing. There can be a dull chest percussion over areas of the consolidation, which this is not something that entry-level nurses do. This is more of an advanced practice. There can also be decreased O2 sat levels, which you may see sometimes in our more sensitive populations, and also purulent blood tinge or rust color sputum. It may or may not be present. Throughout this recording, when you actually look at the PowerPoint, I do have some sound bites that you can listen to that kind of helps you learn what the different sounds sound like when you're auscultating the lungs. Diagnostics: obviously if there's an infection, when the CBC is done, you may see an elevated white blood cell count. Chest x-ray are really important in older patients because you just have to remember they can decompensate very quickly, as well as very young children. What you should be concerned about, obviously, is going to be your nursing care, things that you can do to help them, and it's going to be a lot about how to help them bring up any mucus that is in the lower lungs, help better expansion of the lungs. Anytime somebody's having pain and they're not breathing completely, it does kind of perpetuate the pneumonia. So in terms of positioning, high Fowler's helps and allows the chest to expand better. Encourage coughing, deep breathing. Make sure you know how to teach a patient to use an incentive spirometer. Talk to them about nutrition and fluid intake. Obviously, anytime somebody is sick, a lot of times people don't want to eat or drink, and really you need those nutrients to feel better. Encourage rest and medication education, especially if they're on an antibiotic. You want to make sure that they're going to complete it in whole. Complications: ATELECTASIS, bacteremia, sepsis, and acute respiratory distress syndrome, which we will not talk about in this course. You will see that again in critical care. Medical management: they can be on antibiotics. Depending on how difficult the O2 exchange is, they may be on some bronchodilators. Your albuterol gives rapid relief. The Atrovent can also help decrease pulmonary secretions. Theophylline really does need close monitoring because there's a narrow therapeutic range, so if they go beyond that, it can lead to toxicity. So just make sure you know signs and symptoms of toxicity for this, which is headaches, blurred vision, palpitations, and seizures. NSAIDs can help decrease inflammation, and obviously your fluticasone and prednisone, which are going to be your steroids that also help decrease the immune response and typically can help people in the long run. Considerations, again, antibiotics. Make sure you talk to patients about using probiotics, the increased risk of yeast infections, especially in our females, and monitoring kidneys in older adults who are taking penicillins and the cephalosporins. Other medications you want to look for, just make sure, like with the impromptu, that they can get dry mouth, and watch their heart rate, and albuterol can cause some tremors and tachycardia. This is a nice overview if you like your visuals. That just kind of gives a different take of looking at pneumonia, knowing what's happening and the symptoms. This talks a little bit about diagnosing and what you can see. Tuberculosis. When we look at this from a nursing standpoint, make sure you understand the nursing considerations, especially in terms of what you need to be doing when treating this patient and how it is transmitted. Know the signs and symptoms: persistent cough, chest pain, weakness, weight loss, anorexia, frothy, bloody sputum, dyspnea, fever, low grade in the afternoon, night sweats or chills, and sometimes the elderly patient will present with altered mental status. Those that are going to be at higher risk are going to be your healthcare workers, those who travel outside of the U.S. to areas where TB is prevalent, and those who are immunocompromised. What we are familiar with as nursing students and as nurses is the Mantoux test. It needs to be read within 48 to 72 hours. That is what we know as the two-step test. A chest x-ray will see active lesions in the lungs, and doing a acid-fast bacilli smear and culture, if it is positive, it also shows an active infection. Know that it is transmitted by the airborne route. If you're taking care of patients, you need to be properly fitted with an N95 respirator. Especially with our male nurses, if you have any facial hair, know it's going to be a little bit more difficult to get a good seal. If you need to transport a patient, make sure they are wearing a mask. And obviously, anytime anybody is sick, adequate nutrition is going to be important. Make sure you know the 4 medicine regimen, and if you see here the tryptophan, isodiazid, the pyrazidamide, my goodness, and ethibutol, if you see in this order, it spells ripe. That can help you. And also take a look at ATI Chapter 23 on page 137 for considerations in patient teaching. Patient education, hand hygiene, cough and sneeze hygiene. Typically, when they are going through the medical treatment, they need to have sputum samples done every 2 to 4 weeks to monitor therapy. And those with active TB, they need to wear a mask in public. Complications, miliary TB, which can be life-threatening. This basically invades the bloodstream and goes to the organs. Some of the signs and symptoms of that is headache, neck stiffness, and drowsiness. Can also cause pericarditis, which hopefully you still remember what the signs and symptoms of that are. Patients, because it is airborne route, they need to be isolated in a negative pressure isolation room. So remember that, negative pressure, and NCLEX loves to ask about TB and management. So we're going to talk about pleural conditions: pleurisy, pleural effusion, and pleural emphysema. Basically, this is going to be an inflammation of both layers of the pleura. And again, we have another soundbite here. When you actually go through the PowerPoint, you can listen to it so you can kind of get a sense of what a pleural friction rub is like. One way that it was described to me is if you have longer hair, if you rub it between your fingers by your ear, that's kind of what it sounds like. So pleurisy can be a complication of a lot of different infections. But in terms of assessment, there's going to be pain that is worse with taking a deep breath, coughing, or sneezing. It's typically limited to one side or irradiates to the shoulder or abdomen. Big thing is that the pain is severe, sharp, and knife-like. So don't forget this image here. Medical management, obviously we want to treat the pain because this is something that patients are going to talk about. And if it hurts, take a deep breath. Think about in terms of the effectiveness of opening and expanding the lungs for a good gas exchange. So we want to monitor for pleural effusion. That's going to be a buildup of fluid. Signs and symptoms of that's going to be shortness of breath, pain, decreased chest wall exertion, and basically you'll see a patient trying to get in a position that decreases their pain is going to be the most helpful. So the difference between effusion or emphysema, basically effusion is a collection of fluid where the emphysema is actually pus. And it's a type of pleural effusion, so don't get too confused. When you hear the difference, it's just going to be perhaps what the etiology of it is, which talks a little bit more about it here. Symptoms, again, it kind of depends on the underlying disease, but always you're going to see dyspnea, difficult lying flat, and coughing. Emphysema are typically with those who are acutely ill with a more severe inflammatory symptoms. Unfortunately, too, I have seen some emphysemas also related with some different types of cancer. So in terms of assessment and testing, you're going to have a decrease or absence of breath sounds with the effusion. Decreased fremitus and a dull flat sound on percussion. In the case of a large amount, a lot of times patients will need to have this drained. If they're in respiratory distress, there might be tracheal deviation away from the affected area. They can have O2 sats less than 90, hypotension, and tachycardia. Obviously, the best way to diagnose is either through physical exam, chest x-ray, chest CD, CT, ultrasound, and the thoracentesis can confirm the presence of fluid. If a thoracentesis is done, they're basically going to pull or drain that fluid off. A lot of times they're going to want to send that out for culture and sensitivity before starting any antibiotics to be more effective. And also a biopsy may be done. Like I said previously, sometimes it can be a result from cancer. Medical treatment, treat the underlying condition, drain the fluid by a thoracentesis. What we can do for patients is if they have a thoracentesis done, they're probably going to have a chest tube placed. So you need to be able to monitor the chest tubes, troubleshoot any problems with those. Pain management, splinting while coughing will help in monitoring the effectiveness of any pain medications. So like I mentioned in class, I'm really not going to go over chest tubes. There's a 10-minute video that I have highly suggested that you review. You will see anywhere from 3 to 4 questions on your exam regarding it, so make sure you watch it. Trauma-related, you don't need to know a whole lot about these, but just make sure you understand, if you ever hear the terminology, what it is. So rib fractures, obviously is going to be a fracture of the rib. Typically, in terms of management, it's not going to be surgical, but just to show you some of the different signs and symptoms. Diagnostics, a lot of times there's going to be pain. There's no surgical intervention. Most times they heal in 3 to 6 weeks. It's just going to be a matter of managing it. Pulmonary contusions, this is a thoracic injury associated with a blunt trauma resulting in abnormal accumulation of fluid in the interstitial and intra-alveolar spaces. Again, just make sure you are familiar with what it is and what some of your clinical assessments are and diagnostics. And hopefully you've seen that most diagnostics are going to include a chest x-ray. Cardiac tamponade, we have this in our cardiac unit, so I'm not going to spend a lot of time on this, but just basically know that this is when there is a compression of the heart that results from fluid or blood within the pericardial sac. and it can happen from a result of blunt trauma to the chest. And again, know what the management is. So you're going to have the pericardiocentesis, and what you can do as a nurse is encourage that patient to sit in a tripod position. Pneumothorax, hemothorax, just know again what it is. Pneumo obviously is going to be air that is in the pleural cavity that typically is from a result of a lung collapsing, and you can see all the different ways that can cause it. Treatment obviously is going to be a chest tube and giving that patient O2, going to be diagnosed by chest x-ray and ABGs. Here's some of your signs and symptoms. And hemothorax is basically going to be when there is blood in the pleural cavity that can result in compression against the lung. Pneumothorax, in terms of nursing care, patients are typically going to be administered O2 therapy. So just kind of understand some of the basics of your mask. Nasal cannula, the Venturi, the non-rebreather, has the page numbers here where you can look at it. And quite simply, make sure you know that Venturi mask is a mix of room air and fixed flow of O2. A non-rebreather basically is considered high flow, and the patient is getting 100% O2. Subcutaneous emphysema, this is kind of neat. If you ever have been in a surgery, sometimes over a long period of time with like laparoscopic surgeries, when they do the placement of the ports, sometimes air may enter the tissue planes and get underneath the skin, and really what ends up happening is when you just kind of indent the skin, you can hear the snap, crackle, pop. It does dissipate on its own, but it can be disconcerting to some patients. Complications, pulmonary embolism and atelectasis. Again, make sure you understand what they are. If you don't have an understanding, it's going to be very difficult for you in order to know what you need to do with nursing management. So basically, a pulmonary embolism is when a substance, it can be a solid, a gas, or a liquid, enters the venous circulation and forms a blockage in the pulmonary vasculature. Okay, so ways to help promote or prevent them is tell people to stop smoking. Make sure somebody is the appropriate weight for their height and frame, healthy diet and exercise. Prevent DVTs by leg exercises, compression stockings, and avoid sitting for long periods of time, because really it's about blood pooling and a clot being able to form. And then what happens, that clot breaks off and it travels up to the lungs. So risk factors can be long-term immobility, pregnancy, those in OB. Hopefully you remember that in pregnancy, the amount of blood in a woman has kind of doubled. So if you think there's more to circulate, there's a higher risk for clots. Long bone fractures, and obviously being a little bit older. One type that is most common is going to be our DVT, which is a deep vein thrombosis. Findings, anxiety, feeling of impending doom if somebody basically you'll hear has thrown a PE, pain upon breathing in, chest wall tenderness, dyspnea, air hunger, cough. They might have some bloody sputum. Labs, obviously you see there's a long list of physical assessments, but some of them that you're going to see is going to be these top ones, okay? Another thing, make sure with like DVTs, you know that if somebody is suspected to have it, do not massage the leg, for Pete's sake, because you could dislodge it. So no massaging of legs, please. Nursing care, if somebody's suspected of having a pulmonary embolism, there really is a high rate of mortality, but some people have actually survived from these, okay? So O2 therapy, high followers, monitor respiration, cardiac status, emotional support. You want to try to keep them calm. Watch their mental status. monitor their PT levels, educate them, especially after they hopefully have successfully survived one, education about bleeding risks and how to further prevent any additional thrombus. And what is really neat here when you go through the PowerPoint, if you have a few minutes, I didn't pick a very long one, but it's just interesting. This is a woman who basically talks about her recovery of a PE and really kind of talks about some of the emotional toll that has gone along with her recovery. Medical management, anticoagulants, thrombolytic therapy, which are clot busters. Make sure you are familiar with the different drugs that are used. Sometimes they may do an embolectomy, which is actually going in and removing the thrombus, especially if it hasn't gotten to the lungs. But also people who are at higher risk, they may do what's called a vena cava filter, that basically kind of filters and keeps the clots from traveling up into the lungs and heart. Those who are visual, here is a really good representation of different signs and symptoms and causes. Atelectasis, this is a collapse of the alveoli leading to the loss of lung volume that can cause mismatch of lung ventilation to perfusion, which basically results in deoxygenated blood supply to the tissues. So not getting a good gas exchange. There can be different types, but just make sure you know generally what atelectasis is and know the patients who are going to be at higher risk of it. So we see surgical patients, those with chronic lung disease, those who are obese, tobacco use, anesthesia, time greater than 4 hours, a prior CVA, lung cancer, pleural effusions, and NG tube placement. Here's some more information about clinical presentation. Sometimes it can be small areas that are affected versus large. Goals for at-risk patients is basically, if they're at risk, let's prevent it, okay? So change their position frequently. This is something you can do as a nurse. Hint, hint, things you should know. Encourage early mobilization from bed to chair followed by early ambulation, especially after surgery. Appropriate deep breathing and coughing to mobilize any secretions and prevent them from accumulating. Teach and reinforce techniques for the incentive spirometer. Since you've seen this a few times throughout this PowerPoint, I hope you know how to educate somebody to use it properly. Administer prescribed opiates and sedatives to prevent depression, which is kind of strange here. So sometimes opiates obviously can cause respiratory depression, but if somebody's having a difficult time breathing and having a little bit of opiates on board will actually help them have better lung expansion, but you just need to watch that it doesn't lead to depression. There's always going to be sedation first before depression. Perform postural drainage and chest percussions if it is indicated, and suctioning to remove any secretions, again, if indicated. These patients might be on a nebulizer, bronchodilators, mucolytics, and chest physiotherapy. Basically, it's some percussion that kind of helps break things up to allow it to drain better. Chest tumors and cancer, again, don't need to know every last detail about these, just have a sense about what they are and what they do to patients. So obviously, the #1 risk factor with lung cancer is going to be tobacco smoking. Make sure you know how to assess a pack year history, which is basically the number of packs smoked per day times the year of smoking. Passive smoking is going to be your secondhand smoking and environmental and occupational exposures, family history, and low intake of fruits and vegetables. Oh, and also too, one of the hallmark symptoms is a chronic cough. Occupational lung diseases, again, just know that some folks who have certain occupations are going to be at higher risk of having issues. And this is one of like the longest words. I believe it's a pneumomonal ultramicroscopic silicovolcanoconiosis. It's an awesome word. This gives you an idea of what certain occupations can do breathing in, whether it's coal dust or cilia. This right here is black lung disease, asbestos. So those like who are abatement workers, if they're not wearing proper respirators, they're going to be at higher risk of having issues. Unfortunately, these are not curable diseases, and so manage is going to be about supportive in terms of working with these patients. All right, so let's do some review here. Pack year calculations. We have 1 pack per day for 10 years. Take a moment. I hope you said 10 pack year history, a half a pack a day for 20 years. And the correct answer is 10 pack year history, and 2 packs for 10 years and 1 pack for 5 years. Believe it or not, people sometimes will smoke for a long time, have a hiatus, and then they pick up smoking again. I hope you said 25 pack year history. So take a few moments, and I want you to write out some nursing care for patients with pneumonia. What can you do? You can pause this. We're going to have 1, 2, 3, 4, 5, 6, 7, 8, 9. So write down 9 different things. Number 1, position the client for maximum ventilation, high Fowler's. Encourage coughing or suction to remove secretions. Administer breathing treatments and medications. O2 therapy. Monitor the skin breakdown around the nose and mouth from the O2 device. Encourage deep breathing with an incentive spirometer to prevent alveolar collapse. Determine the client's physical limitations and structure activity to include periods of rest. Promote adequate nutrition and fluid intake. Reassure the client who's experiencing respiratory distress. So let's talk about protecting yourself and your patient with TB. So you want to make sure that the patient is in a negative pressure isolation room, which basically ventilates the air through like a HEPA filter out. As a nurse, you should wear a N95 mask and make sure it fits properly. So you should have yearly fit tests. When you're transporting your patient, make sure they're wearing a mask. And let's talk about the medication regimen for active treatment. Hopefully all this you knew, and if not, please make sure you review it. So that's about it. If you do have any questions, again, remember, you are really working towards to being an entry-level nurse, and so it's always going to come down to making sure you keep your patients safe and you keep them breathing. And when we talk about lower lung diseases, that's going to be really important. Take care. Bye-bye.